Welcome back to Psychiatry Bootcamp. Today we are discussing the most psychic consult of all time, Decisional Capacity. We did an episode on this in season 1, but this episode goes into a little bit more detail and is designed to more closely mirror the recent APA practice guidelines on this topic, and it discusses the Appelbaum Grisso criteria in more detail. I'm hoping this episode is widely shared among all health professionals because, as you will hear in the vast majority of cases, determination of decisional capacity does not require a psych consult. I honestly think that if you are a med student, off-service resident, advanced practice provider, or non-psychiatric physician, after listening to this episode, all of your prior training on the topic will come back to you, and you will be able to provide higher quality, more efficient care because you will feel confident doing your own capacity assessments. And maybe this is an invitation to our psych residents to share this podcast with your colleagues who are consulting you. So my guest today is the senior author on the 2019 APA resource document on decisional capacity determinations and consultation liaison psychiatrist extraordinaire, Mira Zein. Welcome to Psychiatry Bootcamp, Dr. Zane, and I will ask you to introduce yourself to our audience.
Hi, everyone. So I'm Mira. I am a clinical associate professor at Stanford as part of the consult liaison psychiatry team. I work in integrated behavioral health, and I work at San Mateo Medical Center on their consult team and in their psychiatric emergency. And I also am an author on the 2019 APA resource document on decisional capacity determinations and consult liaison psychiatry. I'm going to call it CL psychiatry as we go forth through this. It's a helpful step-by-step guide for general psychiatrists who are called on to be in a CL role or even a psychiatric emergency role. So it's helpful to read and take a look at, and it will guide what we're talking about today.
It is ridiculously helpful, and we will link it in the episode notes as well. I would really encourage everyone to take a look at it. So talking about capacity consults, I think of all consults that psychiatry residents get, this is the one where psychiatry residents throw the most shade, roll their eyes sometimes. And I want to center us around the importance of our task here. So despite the fact that some psychiatry residents might get annoyed by capacity consults, why is it so important? What is at stake?
So I think about guiding ethical principles of psychiatry and that idea of beneficence. We are trying to do good for the patient, as well as non-maleficence of we're actively trying to not do harmful things, and also thinking about patient autonomy. So in weighing on capacity decisions, we are looking at a patient's autonomy to make decisions and what are the risks and benefits of doing that, and can they make that decision well? So this can be everything from life-saving interventions to very small interventions, but ultimately we are helping to shape how a patient is going to be treated in a hospital setting or potentially even an outpatient setting.
And in thinking about the decisional capacity consults, I guess the first place to start is sort of receiving the consult, fielding the consult. So let's say you get a consult from internal medicine and they say, we're consulting you for capacity on the patient in 101. What would be your first step in fielding that consult?
First up, I want to know is what is the specific capacity question they're looking for? Because oftentimes teams will just want to have a blanket. This person doesn't have capacity to make decisions, and capacity assessments don't do that. That's a legal competency evaluation of is a person competent to be making decisions for themselves. Capacity is asking a specific question about a specific choice. And oftentimes when we are making that capacity evaluation, it's a cross-section of a moment in time. So I want to know, what is it? Are they refusing, lab draws? Are they refusing to have an evaluation for lung cancer, which is one of the patients on our service right now? So what are they asking? And also, what are the steps that they've taken to look at that so far? What sort of conversation has that been?
So why does this matter? By which I mean, can I just take a sample decision is this patient able to consent to a aortic valve replacement procedure, let's say, and then apply that decision to all other cases where the patient might be making a medical decision? Would that be one way to approach it?
No. So I think, again, that becomes that legal competency conversation that is, determined by a judge and a lot of other factors, because patients can have a differential. So when we think about a differential capacity, or we think of a spectrum of decision-making capacity, a patient might be able to make a decision about one intervention. Let's say, they are able to understand that they need lab draws because their potassium is consistently low and they need to know you have a discussion, they understand that. But for the aortic valve replacement, you walk them through those decisions and they just can't be able to provide you the information of what that means.
So decisional capacity is determined on a sliding scale, meaning more complex decisions like open heart surgery would require a higher level of capacity than more straightforward, low risk benefit ratio decisions like refusing Tylenol for a headache. Is that right?
I think that's fair. I think you're looking at the risk of the intervention and also the risk of not having the intervention. So I'd say sliding scale, or I think of it like a Punnett square type of thing from genetics where we're mapping out risks and benefits. And so, right, if a patient is refusing something complex, but that complex thing will really not have significant benefits for their treatment or might have a lot of risks associated, then they might not necessarily need to have right as high a bar. But if someone's refusing a life-saving intervention and there's not that many risks, then their capacity bars can be much higher because of just the fact that they're refusing something that's so important.
Very concisely put. What would you say are the most common reasons for capacity consult that you've seen? Like, what types of things are happening with a patient that lead the primary team to say, I might want a second opinion on this to make sure that this patient fully has the ability to make this specific decision?
Yeah, I'd say bar none, the number one is refusing some sort of medical treatment, right? So we never get consults for this patient is agreeing to treatment. Is that okay that they're agreeing to treatment? It's always refusing something. And that also includes refusing disposition. So I think most common that we are being seeing on the CL service these days is refusal for placement, either at a SNF or at right, a long-term care facility. And oftentimes we'll see for those specific dispositions for like SNFs or long-term care that there are neurocognitive issues that might be impacting those decisions.
So it's a combination of the patient factors, meaning if there's a neurocognitive process, a delirium, a major neurocognitive disorder that gives the primary team pause, and then you couple that with the choice the patient is making is not in line with the physician's recommendation. That would be the perfect storm for needing a capacity consult.
Yeah.
So let's talk about the elements of informed consent. And I want to specifically name the criteria here because I did do an episode on decisional capacity in the first season, and I did not mention these criteria by name. And it absolutely haunts me. I mean, it is educational malpractice it really is, to not mention the decisional capacity criteria by name. So, Dr. Zane, what criteria do we use to determine decisional capacity and where does it come from?
So I think the gold standard are the Appelbaum Grisso criteria. There's the seminal 1988 article. They wrote subsequent articles after that, and there have been other ethical psychiatry articles that kind of reinforce these ideas. But there are those four cardinal criteria from the Appelbaum Grisso criteria. So it's understand, appreciate, exhibit that rational treatment, and then communicating that consistent choice. And so when we take those and like think about what each of them means, right? We've got that communicate choice, so that can the patient literally indicate their preferred treatment, and that is including right. Can they be consistent about that? So Grisso makes an interesting point in that article that right patients can flip flop back and forth, frequently, even though they're expressing choices. The fact that they're being ambivalent can suggest that they can't communicate that consistent choice, right? And they understand the relevant information. So can they actually like take the information and be able to like repeat back that understanding? So not like parroting or not just agreeing to what you're saying, but actually be able to summarize the information given to them and bring it back. And then can they appreciate the situation and its consequences? So, right, can they take that information, apply it, and then reason it back to themselves and be able to think about kind of the rational ideas there? And then, like, that last part is, right, are they able to show that they're having this rational process for decision making? So their decision isn't based on a delusional thought process, or their, decision isn't just based off of confabulation or something else going on.
So communicate a consistent choice, understand, appreciate, and then ensure the thought process is rational. And we will drill down on each of those. Before we do that, does the patient need to satisfy all four of the Appelbaum Grisso criteria in order to be found to have capacity? Or if they can satisfy three and you're a little wishy washy on the fourth, then we say it's good enough. What's our cutoff for the Appelbaum Grisso criteria?
Yeah, so they do need to satisfy all four. Again, right, it becomes that spectrum. And so that's where when we think about there's no one cutoff, but I've done capacity evaluations in patients who are intubated, and then we've broken down each question into like simple yes and no's that they can nod or shake their head to. And then kind of thought about that in that sense. So it really does again depend on that kind of risk benefit spectrum terms of how detailed do we want them to be explaining each one. But you do want them to be hitting all four criteria because you don't want someone, for instance, to be, refusing something and you say they do have capacity because they have the other three, but they think that they're refusing it because people are like meddling with their brain and putting chips in their head, for example.
That makes perfect sense. You need all four in order to be found to have decisional capacity to make that specific choice. Let's drill down into communicating a consistent choice. This is the one that I'm most excited to kind of query you about because, Dr. Zane, people are allowed to change their minds, right? So where do we? I mean, to be frank, where do we draw the line between a person just changing their mind about something and saying this person is not communicating a consistent choice and therefore they do not have capacity to make this specific decision?
Yeah, so I think so. Probably the easiest example is someone who's delirious, for example. And so as they're going through and have ins and outs of how, you know, with it they are in terms of level of consciousness, they might also then be changing their decision depending on how confused they are. And so in that, even though they might be making statements of decisions, then right, they're not able to clearly state it consistently. Or I had another gentleman who was refusing an amputation of his foot, and it was septic, and it was potential to spread to the rest of his body. He was getting quite sick, and he would agree to it, and then he would, then change his mind and then agree. And we did several instances over a matter of days where he kept flip flopping back and forth, and working on, whether it was fear, whether it was, due to other, issues underlying. We did a neurocognitive assessment, and then it was because it was getting worse and he just kept flip-flopping back and forth and couldn't give us really good reason why that was happening. We ultimately had to say he was lacking capacity. We weren't able to restore the capacity at that point.
Copy that. And so that would be an area where, because the choice was not consistent, that really informed your decision on whether or not the patient did have capacity. It's a good example, too, of where, as the medical condition changes, that can have an impact on the capacity. His capacity, as his infection got worse, maybe delirium set on, maybe the delirium got worse, et cetera. I think the other example that I saw that was really intriguing to me was a patient who was full code, but in order to be full code in this patient's particular circumstances, you had to stay on the floor. And this patient wanted to be able to go to the cafeteria, wanted to be able to go outside and smoke a cigarette. And so the patient would say, change my code status. I'm not full code anymore. And then he'd come back on the floor and say, now I want to be full code again. And so it was like, is this a consistent choice? I will say that was a challenging one for me because I see his thought process, right? I don't know that wanting to go to the cafeteria, I don't know that in my reasoning process, wanting to go to the cafeteria trumps changing my code status, but I can certainly see that perspective. What would you say in a case like that? Is that patient communicating a consistent choice?
So I think they're communicating a consistent choice about something, right? Which is they're communicating that they want that autonomy of being able to do the things that they want to do, but they also want to be cared for in that. So I think that's an interesting instance of is there some sort of compromise can be reached in terms of patient placement, and status so that he's not just flip-flopping code back and forth.
Right. He wasn't changing for no reason. He had a reasonable thought process. And that is the way we approach that was sort of let's look at the system and say, is there a way we can readdress, sort of these artificial barriers? Is there a way we can look at those and make it make more sense for all parties involved?
Yeah. And I think the other thing to think about with the communicate part is, right, there are patients, for instance, that have strokes, all right, and they might become nonverbal, but being able to exhaust that you are finding other ways of trying to understand what their choice might be. Because people, as long as they're having receptive ability, hopefully they're taking in the information. So can they write potentially? Can they blink? Are there other codes or things that they can do to communicate that we have, not addressed at that point in time?
Right. So it's communicate a consistent choice. It's not communicate a consistent and convenient, quick choice, right? Sometimes we need to be really patient to get this criterion, really be maybe kind of creative in how we are assessing their ability to communicate decisions. So point taken there that we may need to really sit down and maybe get multidisciplinary team involved and say, what is the best way for me to communicate with this patient? Because it's not very quick or convenient.
Yeah.
Next task is understanding. As the physician, how would you recommend that I approach the patient to assess for understanding?
And so, in terms of understanding the information, the first part is that I need to make sure that I understand the information. And so, if it's a complex surgical or medical question, I'm going to sometimes even just bring the primary team with me to have that conversation. And when I do that, I then can also fill that CL psychiatrist as educator, CL psychiatrist as liaison, see how they have the conversation, be able to kind of provide feedback in terms of their conversation with the patient, but then also hear it from their lips and then say to the patient in real time, this is what I'm hearing. They're saying, what is your understanding of what the team just described to you? And I might do that in different situations, but I might go with the physical therapist and see how the patient is interacting with the physical therapist. And if they're understanding kind of the comments that the physical therapist is making, can the patient respond to that? But ultimately, having that conversation about the assessment, I want to make sure the patient can summarize in their own words if they understand both what is the recommendation and what is going on with them, and then as we said, expressing their choice and why they're making that choice, and can they understand the risks and benefits of the choices that they're making. So we're asking a lot in this understand piece of things, right? And so we want to kind of if that kind of does the understand and the appreciate as well in a little bit at the same time, but we really want to see if they can grasp the meaning of the information that is being communicated. Can they then, after they've grasped that, then manipulate that information to in their own words?
When you get into the manipulation, is that more the appreciation task?
It is the kind of the appreciate and then also be able to apply it to themselves. And so this really interesting example, I had a patient who was bipolar and they were in an actively manic state. And they had jumped off of a ledge and they had fractured their leg, and so they needed to have a surgical intervention. And so they were refusing the surgical intervention, and they were refusing medications for bipolar disorder, and so we were trying to restore them to capacity. And so they could understand that the idea of having bipolar disorder, they understand the idea of, a mania causing something. They could understand the idea that refusing treatment could lead to these consequences, but they couldn't appreciate that that applied to them. So they didn't appreciate that that was their views of their medical decision. So understanding and appreciation go hand in hand together when we're assessing one versus the other.
That makes perfect sense. And I think in defense of our psychiatry residents who roll their eyes at these consults, this, what you mentioned about bringing the primary team with you, I think speaks to the point that often it is the primary team, it is the team doing the procedure, it is the team proposing the intervention that really is actually in the best position to perform a capacity assessment because, there are a lot of medical procedures that I remember learning about in medical school, and I probably couldn't even tell you what the acronym stands for anymore for some of them. So, in terms of what the full risks and benefits are, probably the best person to do that in many cases is the primary team. Would you agree, or would you say if you were able to choose, you would have a consult psychiatrist do this every time?
So I think I agree the primary team is in terms of the information that they carry, and then but in terms of the communication style and whether or not they're going to be able to communicate that effectively, the patient can vary. So oftentimes, right, that is why we get called. There's also, right, of course, the liability perspective. There is this perception that having this consult psychiatrist sign off of it and it helps improve any sort of liability. But I think having the joint psychiatrist and primary team member, if the primary team person doesn't feel comfortable making that evaluation go, is the best of both worlds because we are ideally positioned to be able to translate right to the patient essentially and help to ensure that the information is reaching them in a way that they can comprehend.
That makes perfect sense. So we talked about communicating a consistent choice. We talked about understanding the factual information. We talked a little bit about appreciating the information that is, placing it in your particular context. What are the consequences of the decision going to mean for you? And maybe this last criterion gets to your point about this is an area where a psychiatric specialist, a psychiatrist, really probably could be very helpful, is this rational thought process. So if I'm trying to determine whether or not the thought process is rational, what approach would you recommend that I take?
Yeah, so I think, it's just a kind of the simple open-ended question of why is always a good place to start, right? So if, asking if someone is refusing, as this, patient with mania did, like refusing this, right, surgical intervention or refusing medications, it's like, oh, can you explain to me why? Like, what is, would love to understand your reasoning, and doing it in a non-judgmental way, but coming just from a place of curiosity of like, I just want to understand more. Like what your perspective is, and then seeing how they respond to that. And then, so for the patient who said that he was going to have his fracture, right, be like healed by God, and thus he, did not need any sort of intervention because he was divinely touched, then like, oh, okay, you know, that's, it's an interesting perspective. Tell me more about what happens if it doesn't heal in that way. What would the possible consequences be of that? And then see how they're able to respond to it. And so, being able to assess, down the line, both the general, like what their rationale is, and then what is a thought process around what is governing that rationale. So people can make bad decisions, or they might not have sufficient health literacy. Those are things, when you're trying to think about the reasoning, how you're going to intervene to try and restore capacity. Like, what is the underlying cause? Is it that they have a psychiatric condition? Is it that there's a neurocognitive issue and thus they're not able to actually process and maintain and manipulate the information? Is it that they just don't have the health literacy, and so we're going to continue to try and provide education?
Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice has been a great partner for us because, as you know, I find time with the patient to be a therapeutic intervention more than documentation. So Simple Practice makes documentation easy. They have an AI-powered note writing tool integrated within the EHR. So it's a true all-in-one EHR. It's HIPAA compliant, it's high trust compliant, and now it includes AI. What more could you want? Simple Practice saves you time so you can focus on what matters most. They're offering Psychiatry Bootcamp listeners a 30-day free trial for their AI note taker and an exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR. Visit simplepractice.com/bootcamp for this offer. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 exam style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exam, and I found that it made the exam a breeze. It really reflected the real exam. Give it a try. Beattheboards.com/bootcamp. I'd like to ask you about a couple of sort of edge cases because I think those are good cases to kind of tease out how these criteria really apply. So the first one would be a patient who refuses a vaccine because they believe the vaccine will be harmful to them in a way that is not supported by scientific understanding. Um, would we say this is not a reasonable thought process? This patient thinks that this vaccine is going to do something to them, but there's actually no evidence for that, and it's factually wrong, and it's a fixed false belief. And so this patient does not have a reasonable thought process, and therefore they are not able to refuse this vaccine. How do we think about this?
This is a very good and kind of interesting question. And I think it'd be come up in kind of what is the context? Trying to be politically appropriate here.
For sure. We are on the internet.
What is the context of which they're refusing? How are they responding to the other criteria? What is the rationale behind their process? How do they respond to other information being provided to them? And then the other context is, let's say that they don't have capacity, right? Their belief is coming from no scientific basis. You provide them with a lot of education. their rationale really isn't making sense, then there's always the question of, okay, they don't have capacity, now what? Right? Are you going to hold them down and administer the vaccine against their will? So in the hospital, right, we have restraints. We can do that potentially, depending on that risk benefit scale. Again, that doesn't make sense if we're going to breach patient autonomy. In an outpatient setting, do we have the recourse to be able to do that? Right, either politically or through law to do that. And so that becomes an entirely different conversation.
Sure. I feel like this often comes down to, am I dealing with an overvalued idea, something that maybe is reasonable and has some cultural support? There's a particular part of the culture that shares this idea that I very strongly do not agree with? Or am I dealing with a thought process that is psychotic, that is clearly abnormal, that does not align with a particular cultural subgroup? And I think vaccines kind of are the perfect edge case for that. The other case I wanted to ask you about is patient who attempts suicide. Suicide is not completed. They're in the ICU and they say, please withdraw all care. I wish this had worked. Does that patient, under those circumstances, typically have the capacity to make that decision? And if not, why not?
Yeah, no, it's a great question. Again, that oftentimes becomes context specific in terms of all the other things going on, but usually someone who has had a suicide attempt has had that attempt in the setting of severe depression, in the setting of, potentially a psychotic disorder. So you want to understand the context, right? You want to do the full evaluation. And when you're doing a capacity evaluation, you're also doing, a full psychiatric evaluation on top of that. And oftentimes you're pulling in neurocognitive evaluations and other aspects to see what their cognitive status looks like. But oftentimes those patients, they are making those decisions through a lens that is not in a rational process, right? And so you'd make the argument that this patient is depressed to the point that their interpretation of the world is altered, and thus we don't think that they have capacity because they're not having that reasoning that is based in a rational thought process at this time.
Thank you. That is extremely clear for me and always a very difficult consult to see and to complete. Is there a role for psychiatrists when we're doing capacity assessments to actually modify these criteria? Meaning, as a psychiatrist doing a capacity assessment, am I expected to provide information that might change a patient's decisional capacity, that might enhance their understanding, appreciation, etc.? Or am I just an impartial umpire calling balls and strikes?
Yeah, no, it's a great question. So, a part of capacity evaluations and part of the consult process is, if we find they lack capacity, is to try and help restore them to capacity. That's not our sole role, right? That's going to be a team role. We're going to ask everybody to be involved in that. But when we do that initial consultation, we're doing just the understanding of, okay, what is their capacity? And then if we make the determination that they lack capacity, kind of, can we provide also evaluation of why do we think they lack capacity? And are there things that can be potentially corrected, right? So are they delirious? Are they depressed or psychotic? And so can have treatments to be able to do that. So you want to be able to provide intervention. And oftentimes it's also, how is the information being provided? So can you change the way that the interventions are being explained? Can you have, graphical, images and illustrated formats? Can you break it down in a different way that can make it more accessible for a patient? So there's been interesting studies looking at even patients who are acutely manic, for example. If you repeat interventions where you provide information in different ways, even during the time that they're acutely manic, they can be restored to decisional capacity, regardless of whether they're receiving medications or not. So there is definitely a place for intervening and helping to guide the team to restore a patient's capacity.
Both and in that case.
Mhm.
And when we are completing a capacity assessment, you mentioned this briefly. Is it acceptable for me to simply walk the patient through the Appelbaum Grisso criteria and make a decision? Can I sit down, introduce myself, and get right down to business with the 4 Appelbaum Grisso criteria? Or would you recommend a more comprehensive approach?
No, you absolutely want a comprehensive approach. And so thinking about, you want that standardized psychiatric interview. And I'm thinking even of a patient that I have right now on our service who has a long history of schizoaffective disorder and some probable neurocognitive disorder, but she's really good at like parroting what, she's gotten used to parroting what people want to hear back. So at face value, if you just went in and like kind of boom, 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 ask the criteria, she might pass. But if you do the deeper dive of the full standardized interview, you get the collateral history, right? You do a deep dive into the chart. You do like kind of a mocha or, so we did a mocha with her and some basic neuroscop. There's other aspects that come out that are concerning. And that made us think, let's do deeper dives in the conversation as well. And let's kind of track over time and see how she responds. And what we ended up getting is that her answers changed. And the more details we asked, the more things fell apart. And so you absolutely want to do kind of the standardized, right, a full psychiatric interview. You absolutely want to think about, particularly in older patients, or patients where there's possible concern for neurocognitive issues, a workup. So kind of thinking of doing a MOCA, doing a slums, having physical or occupational therapy potentially weigh in and do their assessments and see how the patient will respond as well.
So you mentioned the MOCA, you mentioned the St. Louis University mental status exam, which I am always thrilled to hear. When I'm doing a capacity assessment, is there a standardized instrument like one of these tools or a different tool that I can reach for to do the assessment for me? How do these standardized instruments fit into a capacity assessment?
Yeah, so there are instruments out there. There are things like the MacArthur standardized one, both for research and for treatment. They can be useful as supplements, but there's no gold standard beyond the Appelbaum and Grisso criteria. So what I would say is you can use those kind of standardized semi-structured interviews or scores to help supplement and provide additional information. Same thing with using the MOCA or the slums. They're providing you additional information that can help provide contextualization and help with your argument for one way versus another. But really, what it boils down to is you want to have a very clear understanding of those four criteria and how patient is responding. So your evaluation is the most important thing.
Ultimately, it does come down to your clinical judgment. But if you get a slum score of 5 out of 30, that's a pretty strong piece of data that can inform your decision.
Right. Yeah.
I'm sure I can't even imagine how many papers you read when you were creating that APA resource document. So I'd like to ask you a little bit about the literature here. Is there any literature on what disorders are the most common reasons for lacking capacity?
Yeah, so I'd say psychiatric disorders are actually not as common as you'd think, which is interesting. So the number one is cognitive disorders. And so thinking of both if you treat delirium as a cognitive disorder that is potentially reversible, and then a neurocognitive disorder, so a dementia of some sort. Now, just because you have those does not mean that you do lack capacity. And so I think it's important to still do the evaluation and not just assume someone lacks capacity because they have those neurocognitive disorders. But they are at much higher rates. So some studies, I'd say an average of like 54% is what I saw in a lot of studies and like in the 50s. But it really ranges depending on the study. Substance use disorders, especially when people are acutely intoxicated, substance use disorders are this weird area where people can have really poor decision making and you can argue that they have changes in the neurocircuitry. But once they're done being acutely intoxicated, like they can actually potentially speak to the criteria pretty well. And then psychotic disorders. So whether that's a primary psychotic disorder like schizophrenia, or if it's major depression with psychotic features, people who are depressed actually like it takes a lot for them to lose capacity. So in that case you described of a patient who has tried to die by suicide, but oftentimes people who are depressed still do maintain capacity.
In thinking about the different types of questions that we are answering when assessing decisional capacity, I think of basically two major categories. The first is decisional capacity for informed consent, that is to accept or refuse medical recommendations for a procedure, for a medication, etc. The second is dispositional capacity. What is dispositional capacity, and how does your approach differ when you're evaluating dispositional capacity versus decisional capacity for informed consent?
Yeah, I mean, so I think, and big props to one of my colleagues who wrote the guide as well, James Bourgeois. He wrote that paper in 2017, and so this is kind of this idea, and you can think about dispositional capacity as like how are they going to take care of themselves after discharge. You can also consider like discharge capacity because dispositional capacity can sometimes be used to describe like someone's right financial capacity or other dispositional aspects. And so you want to know, are they actually able to manage or take care of themselves, right? When they are leaving somewhere. So if someone is wanting to leave AMA or if someone wants to return home, right, and saying that they're going to be able to take care of themselves at home, then you're doing all the things that we've discussed, but you're really kind of focusing on a multidisciplinary team approach where, like, for instance, occupational therapy, physical therapy, their assessments of how this patient can actually take care of themselves become really important, as well as thinking about, right, social work assessments and care management of what's going on in the home, right? Is APS involved, for example? Do we need to have, right, Institute of Aging, when we think about for California, involved as well? Can, right, if they meet with someone from pharmacy, are they able to actually name their medications and organize them in a way that makes sense? And so just because a patient says that they can take care of themselves or just because a patient can give lip service doesn't mean that's necessarily the case. So I have a good example of that patient I mentioned who has neurocognitive but schizoaffective, right? She has coasted emergency rooms over and over again. And she always says, oh, I'm going to go to this shelter and I am going to go to this food bank. And so it's always been assumed, okay, so she's meeting those criteria of able to care for self and do food, clothing, shelter. But then if we like kind of really broke it down and then made her give us like details of how would she do step by step, what sort of transport would she take, how would she actually get there from the hospital, work with social work about like how would she navigate resources, do an assessment with the right occupational therapy of how is she able to actually manipulate information about self-care, and then physical therapy about like what is her actual physical status, that breaks down. She wouldn't actually be able to care for herself if she decided to leave AMA.
So in this example, you're not just listening to the patient's answer for the 4 Appelbaum Grisso criteria, check, check, check. You also have to dig a little bit deeper, peel the onion in order to really effectively put your patient first and serve your patient. It's going to require some patience. It's going to require reading the notes and
Mhm.
communicating with ancillary staff, with PT, OT, et cetera, to know, is what the patient is telling me, does this represent a rational thought process, or is the patient's thought process actually not really in line with reality at all? The patient says, I'm going to go do these 3 things, but then when you further investigate it, it becomes clear that these 3 things are not going to be possible. And so it's not a very reasonable plan. In fact, it's a plan that is not based in reality. It's sort of what the patient is imagining ideally they would like to happen, but is ultimately not going to be a reasonable decision.
Right. Absolutely. Yeah, I think that's a perfect summation. And I think we see this a lot for patients who have neurocognitive decline but are very, very afraid of losing their autonomy. This is especially true for older patients that we're seeing more and more in the hospital. And it becomes this very gentle, right, balance of respecting patient autonomy and trying to respect their wishes and acknowledging that they're no longer able to do those things.
So then let me ask you, what happens next, right? So after a capacity consult, let's say we find that the patient does not have the decisional capacity to make the specific decision of discharging home, considering their considerable medical needs and their relatively low cognitive baseline. What happens next? What are our recommendations to the primary team in terms of how they do deal with that patient?
Yeah. So again, that happens next, right? Depends on what the scenario is. In the dispositional capacity assessment scenario, is the reason that they lack that capacity due to a neurocognitive issue, due to a psychiatric issue, due to like a treatable medical issue. So we try and restore capacity in any scenario. If we're not able to restore capacity, then we want to move based on what is the underlying cause. And so for this patient, for example, that I'm describing, there's kind of a combination of psychiatric and neurocognitive features going on. And so we try to treat the psychiatric issue. And then we also are pursuing, right, more of a legal stance of, does this patient require a conservatorship so that there's someone assigned to make those decisions for them to ensure a safe placement. Oftentimes, we are looking for, right, family members that can be good surrogate decision makers if there's no healthcare proxy, and most of the time there is not a healthcare proxy in a lot of these cases that is assigned beforehand. But can we find a surrogate decision maker who can make decisions that are in line with patients' values? And then if not, do they need to have some sort of, right, legal process to represent, but also make decisions on their behalf. And that becomes difficult too, because you are then deciding to take someone's autonomy away. And so you want to be very clear that that is the right decision to be moving forward with.
And ultimately, again, so I feel like one of the biggest pieces we need to get across is that our decisional capacity assessments are situation specific, time specific, decision specific. And so I feel like as a consult psychiatrist, we're comfortable operating in that realm. But now you're getting at what about the patient who we really do not expect at any time in the near future they would have capacity to make any specific decision? And of course, that's a competency question. And of course, that does go in front of the judge. And so it's ultimately not up to us to take away the patient's autonomy in that way. But I feel like kind of the dirty little secret is the judge has no idea how to make this decision, right? The judge is probably subpoenaing our notes, reading the medical record, and just translating capacity into competency in their mind. Do you think that's a fair way to think about it?
So I think they're definitely weighing that. They're also weighing, right, the patient's testimony. They're weighing if there's any other witness testimony. They're hopefully, if they're making these decisions, having right other aspects. But yes, absolutely, how we're describing things and how complete is our assessment is going to help make a determination of what's going to happen for a patient.
So we discussed that in the case of dispositional capacity, we need to be extra thorough with the Appelbaum Grisso criteria and maybe take that extra step of not only the patient has insight, but what is their judgment? Are they able to act in their own best interest? Are they able to do the things that they say they're going to do to make sure that it's a reasonable decision? Other than dispositional capacity, are there any other specific capacity assessments where we are looking to determine capacity using criteria that is different than the Appelbaum Grisso criteria?
So I think that gets into the forensic psychiatry realm. And so the general psychiatrist usually isn't going to be doing those types of assessments. There is like a type of dispositional capacity called financial capacity, where you're like actually wanting kind of, as I might describing, more thorough things. So you want to know, are they able to have declarative knowledge where they're describing right the facts around using money concepts events? Can they like actually do the procedural like handling financial skills and routines? Can they write checks? Can they might make change? Right. And looking at their judgments of their ability to make those financial decisions. And that, and I mean, we discussed dispositional capacity. There's like, it's kind of Appelbaum Grisso plus, but you're wanting to make sure you're also having these additional checks of declarative procedural judgment to make sure that the patient is actually able to make those financial handlings. And that oftentimes a forensic psychiatrist is doing in these types of competency cases to like make the sense that they need someone to be a conservator to handle their financial situation. There's also a similar thing that happens in from a forensic perspective in maternal cases, right? If a child is going to be taken outside of a home, called maternal competency exams, where you are doing an evaluation to see if a mother is able to take care of her child. Oftentimes, right, if you have cases where a mother is actively psychotic or if there is kind of other history, there are a lot of different risk factors that can impact maternal competency. You might be doing that evaluation. I've only done those types of evaluations a couple times and a CL psychiatrist. And there's, again, it's like this multidisciplinary approach where you are doing both that comprehensive interview as well as bringing in occupational, physical, right, looking at right different domains of a mother's ability to take care of her child in during this time.
So in maybe cases where I'll say extreme cases or cases where they really need an opinion from a psychiatrist, as the consult psychiatrist, you have stepped into that role and made that decision?
So I've stepped in to do an evaluation and treated it more like a capacity evaluation where, right, that competency is more of a serial thing that a forensic psychiatrist will do. Because oftentimes, right, in let's say a hospital setting, if you're doing a maternal competency evaluation, you're treating someone when they're in an acute state. And so I can make that capacity evaluation of, I don't think that she has that capacity in this moment. And then a forensic psychiatrist should really be taking over and doing a longitudinal assessment.
Gotcha. Thank you for the clarification. So, again, time specific, decision specific. In this moment, this this parent is not able to demonstrate to me that they have the capacity to be in this role. but that's different than maternal competency, which is a more long-term decision. And what I liked about the APA resource document is it's very encouraging, it's very informative. I think it helps people to um, practice in their full scope, but I think it empowers especially primary teams to make some of these more simple decisions for themselves. But when it came to maternal competency and this person's right to raise their own child forever, the APA resource document was sort of like, stop, do not pass go, do not collect $200. You are beyond your scope for this, and you need to contact a forensic psychiatrist.
Yeah, absolutely. I think you can do a capacity evaluation of, right, at this moment, is this mother, let's say, acutely psychotic or intoxicated, and so not a good idea right now. And so, right, does this person need to be on a hold and treated, and we find, right, treatment in this moment versus we are making a decision to take a child away from their mother. That is a legal decision that's going to have ramifications.
After we have completed our capacity consult, after we've made our determination, what best practices would you recommend for communicating our recommendations to the primary team?
So you absolutely want to document, and and I oftentimes will break down in my notes kind of each of the criteria and kind of discuss my reasoning for each of the criteria of why I think they are or are not meeting that criteria. And then say, okay, and thus based on this, right, I don't think they have capacity. This is the reason why I think is contributing. So what is that formulation, right? And diagnostically, what I think is going on. And so, okay, they don't have capacity to make this decision. And it's good to also clarify, right? But they might have capacity to make this other decision because, right, if they oftentimes will get like consult questions that ask, we want capacity for this and this and this and this. So making sure that you are breaking down for each capacity question, right? What is your reasoning there? And then also making recommendations of, if we don't think they have capacity, what are reasonable next steps for that capacity? And so making sure all of that is very clearly documented, making sure I'm also having a verbal conversation with the team. And then if I have expectations of some sort of intervention, that I'm communicating that, I'm talking to the nurses, I'm talking to the team, or talking to the physical therapists about what things that would be helpful that I'd like to ask to work with them on doing.
I'm getting giddy thinking about all of our very early career learners on their consult psychiatry teams getting to their assessment and plan part of their oral presentation and saying, per the Appelbaum Grisso criteria, and then walking through each of these four criteria. I mean, that's really going to help you shine. And what Dr. Zane's saying is that is exactly your job, is you're applying these four criteria in your thought process. You are walking through them step by step and giving us what you think about each one and why you're making the decision that you make, and then documenting your full thought process, the full diagnosis, the full formulation, each specific recommendation with regard to decisional capacity for a specific decision, and full recommendations for the primary team on what to do next. A couple of final questions for you. Why is it important to conduct repeated assessments in patients at high risk of fluctuating decisional capacity?
I think because it'll help inform, number one, is there something that can be restored? And number two, thinking about, right, is it all, it helps to think about like what is the broader picture. So each of our capacity evaluations is a cross section, right? So if someone is delirious, as I mentioned earlier, right, you might get them at a lucid point. You might get them when they are actively delirious. And so though each of those one points might not give you that clear picture of what's going on, if you get a series of data points over time, that might give you a better picture of, oh, there is this underlying process happening that we need to address so that we can try and restore capacity or make sure we have a better view of what that capacity is. And so that will give us a clearer picture of what their actual decision making capacity is for that. Delirium is the most obvious example, but right, certainly people with a neurocognitive disorder can potentially fluctuate a lot as well. People who are actively psychotic or manic can potentially fluctuate. Or patients who are just having a hard adjustment, like we described that gentleman who was flip flopping right on having the amputation. And so having serial assessments will just give you a better assessment overall.
One thing that has been interesting to me becoming an attending is I think a lot of times, as I mentioned at the start, people in our field think that these are silly consults or consults that we shouldn't have to do, but there is a tremendous amount because once you've done 100 of them, you feel like you can do 100 more pretty quickly. But there's a tremendous amount of misunderstanding about this throughout, I think, all levels of training, all different types of doctors, et cetera. And one thing that makes me irritable, one thing that gets under my skin is when I'll read notes from my psychiatry residents. And as an example, it'll say, we were consulted on this date and the patient was found not to have decisional capacity. The reason that drives me crazy is it's as the experts in the hospital, it's our job to sort of stop misinformation in its tracks and be clear in our documentation. So I would really encourage all of our listeners, when you're making these recommendations, be extremely clear. At the time of my assessment, the patient did or did not have the capacity to agree with or to disagree with this specific decision. I think that when we ourselves are the ones propagating this idea of all or nothing capacity, um, we lose the right to complain about capacity consults. So I would really encourage everyone, make sure to write very clear recommendations about exactly how it is time and situation specific. I guess that's my final thought. That's my biggest pet peeve. I'm on our residents about that when I read that in a chart, because I think that we really can't blame the internal medicine team for asking if the patient has capacity or not when we ourselves are the ones documenting the patient does have capacity or the patient does not have capacity. What would be your final thoughts for our audience on decisional capacity?
Yeah, I think go just kind of adding on to what you're saying, I agree, is that, right, knowing that capacity, because it is a moment in time evaluation, it is not us declaring, for the rest of their hospitalization that they are or they don't. It is something that is evolving. It is something that you can influence potentially and improve. And so it's a great time to learn about your liaison skills with teams, to learn about how are you educating and communicating with patients and with the teams. And so taking it as a learning opportunity can be really, really useful. And I would say there's never a bad capacity question, right? So, right, if a team is asking, it's because they don't feel comfortable making that evaluation, even if it might seem obvious to you that like, oh, they do or they don't. And so it's always good to understand from the team what is the thing that is hard for them, because that'll help with the liaison goal of, what are they battling with? Is there some sort of right transference that is happening because of the patient conversation? Is there right an issue medically and the team is just not picking it up that we can help as a third party? So always think about it from the lens of how can I step in to assist? And then my last thought is that patients might be refusing something and the teams might be frustrated that they're refusing, but then always asking the team of, okay, let's say I find they lack capacity. What is your next step of what you're going to do with this information? Right. So with the lady that I've mentioned who, right, we found lacks capacity, has a potential lung mass, right, that is in there that she's been refusing to work up for, right? If we found she lacks capacity, great. Are you going to sedate her, potentially restrain her, and do right a bronchoscopy so you can get a sample? Are you going to then potentially give her radiotherapy against an over objection if we then find that she lacks capacity? So asking the consequences of the capacity decision, right? And what is the medical team willing to do? What does the ethics committee feel like is okay to do? What does a surrogate feel comfortable with? Are all important considerations when we're doing capacity evaluations. Because it's like, great, we have this information. How do you then want to apply that information as well?
I run into this all the time. That's a great last thought. And I can't help but take the opportunity to pick an expert's brain on it. So are you saying then that in some of these cases, like the case you just mentioned, the primary team might say, upon further reflection, this is kind of a moot point because the risks of restraining this patient doing this procedure against her will, regardless of whether or not she has the capacity to refuse this procedure at this specific time, the risks of that intervention actually outweigh the benefits. And so we actually don't need to make this determination at all.
Potentially, yeah. Or like saying, like, we want this determination, so we have that information to then decide how we might move forward. So it's just making sure that the primary team has thought through if they're asking for this evaluation, what are the next steps that they are willing to then take, right? Are they willing to go to the oncologist and then advocate for this patient to get treatment regardless? Are we going to have the nursing staff be comfortable and provide the training? So it becomes sometimes larger systems questions when we have these complex cases.
I love it. It's just one of those reasons why I love CL psychiatry is having to think this way on a system level. So it's been a real honor to get to spend time with you. Thank you for joining us. Thank you for To be honest, thank you for all your hard work on behalf of all of us CL psychiatrists everywhere. After kind of investigating your bio more, you've been just extremely productive in your career, and I'm sure you will be for many years to come. So I look forward to working with you in the future, and I'm just so grateful for your expertise and for freely sharing it with the world.
Thank you so much. And thanks for the invite to the podcast. It was a pleasure.
Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a human content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.